I'm Ori Hampel. I'm on the board of Docs for Patient Care Foundation. I'm a urologist from Houston, Texas, from the greater Houston area. I'm a closet primary care doctor. Just don't let anybody know. The way I practice medicine is I actually maintain a relationship with all my patients. So like a typical urologist, a patient would come to them with a kidney stone. They take care of the kidney stone, and they say, all right, just call me back if you have another kidney stone. It's not what I do. So, I learned from the board review courses, which you have to take to pass the draconian maintenance of certification boarding in urology. They say that 70 to 80% of kidney stone patients will make another stone. But if you work them up and you do preventive medicine, you can cut that in half. So virtually no urologist does that. Why? Preventive medicine's boring, it doesn't pay as much as procedures, and why would you prevent business? Well, because it's the right thing to do. So for the last almost 26 years in practice, since I've opened my practice in 1998, I've worked up every stone patient, and I've maintained a relationship with them, and I see them twice a year, right before stone season and right at the end of stone season. We have seasons in Houston, not just hurricane season, we also have kidney stone season. So it's when it gets hot, people make stones. Anyway, so I've prevented many stones, and I've caught stones early before the patient ended up in the emergency room, because you do a KUB and they got a little stone, you can blast it. They don't need stents, there's no ER visits, you save a tremendous amount of costs, and you maintain a relationship. And as they get older, now they got a big prostate, I got more things to do. When they get older, I might find a bladder cancer or kidney cancer or whatever, and I can't tell you how many of these patients that I'm sort of a urology primary care doctor. I've discovered certain diseases early in the disease process and was able to cure them and maintain them. So I went to Case Western Reserve University. I graduated 8 years before Lee and Chad did. We went to the same place, and when I was a medical student, for $20 a year, you joined the American Medical Student Association. And I joined because you got a free t-shirt when you joined, and you got JAMA, which I didn't really read much, and because it would have interfered with my playing soccer 6 nights a week. And AMSA, American Medical Student Association t-shirt had a stethoscope and it said, "Preventive medicine saves lives." And Case Western Reserve University really tried to push primary care. They really tried to push people into primary care. They had a mandatory family practice rotation for 2 months in our 4th year. And they failed miserably. And I think the reason they failed miserably in pushing people away from being proceduralists or specialists and into primary care is because they didn't have DPC. So they would put medical students out in the community, and sometimes they were in miserable situations. They weren't with happy doctors who had time to talk to their patients. And so, this is the forum where you fix the primary care shortage in America and you get patients primary care. Anyway, so enough about me. Let's get to the real story here. So we have Nicole Hemkes and Andrew Anderson. I'm going to have them introduce themselves.
So I'm going to be talking about, it might be slightly different, I apologize, than what's printed in your booklet there, but the idea behind this is kind of strategies for growth, success, how you define success in your practice. Maybe all of us have a slightly different definition of what success is within our DPC practice, but I'm going to kind of break it down into different types of practices and kind of what our practice has done. Advocate MD is the name of my practice in Madison, Wisconsin. So back to this idea of defining success, this kind of came into my mind. I'm on a bunch of the DPC Facebook groups, as I'm sure a lot of you are. Been kicked off of one of the DPC Facebook groups. Is there any DPC Docs admin in here? I don't think that they are, but please let me back in. It's been 3 years. I wasn't kicked off for a bad reason, but so how do you define success in your life, in your practice? Again, I think I used the word success in a Facebook post, and someone was like, well, I don't define success as having multiple doctors and multiple clinics. So, maybe for you, it's spending more time with your family. Maybe it's having more autonomy over your schedule. just enjoying your job again. I mean, we didn't go to school for this long and train hours of studying all of this to get into a profession where we hate every day. I mean, I talk to so many doctors that, the question I ask them when we're trying to sell them on joining DPC, and we shouldn't have to sell them, but I always ask them, do you look forward to going to work every day? And 90% of them say no. They have those Sunday night, downs where they're like, oh, I have to go into work tomorrow. So do you enjoy going into work every day? Which I would honestly say for the first time, and after 10 years of practicing as an employed doctor, DPC was what made me enjoy going into work every day. I mentioned, maybe you want to be a business owner. Some people don't want to be a business owner, but if you enjoy that, maybe you have a timeline of, okay, I'm going to work for this many years. I want to do DPC for this many years. I want to retire after that. So kind of defining that for yourself. So again, I'm going to break it down into kind of these different types of practices. And you're going to see a lot of pictures of my two girls in these slides. So hire some child labor when you start. The younger the better. They don't know what they're doing. The top picture, they're cleaning. They're not really cleaning. They don't clean at home either. But the bottom picture, they're just messing around. So when you start out, most of us, almost all of us, I think, we answered the phones. We drew blood. I had to go to a phlebotomy course at the local university to learn how to draw blood. There's a part of it that's exciting and it's cool. You have all the control. You make all the decisions. You design the practice the way you want it to be. There's also a part of it that's very daunting because it's like, unless you go in every day and open up that office, you have all the responsibility. You have no one helping you. If you have a day where you're just kind of like, I'm not feeling it today, it's all on you. So I would say that, there's good and bad to that. You keep your overhead minimal, you're building your panel, you're playing, every role. But I think that there is a high potential for burnout here. And I guess I should have also qualified this talk by saying some of the opinions I will state are not commonly held within the DPC community. They are my own opinions and strategies. But I do think that in a lot of micro practices or one doc practices, there is a high rate of burnout. We've talked about you don't have you don't have coverage when you go on vacation. You have to kind of scramble to do that. You don't have somebody that's necessarily there every day in the office with you that you can, converse with and all of that. So I'm just pointing those kind of things out. So let's say we move to a DPC practice that has one or more docs. There is a benefit to this for the patient, for the physician. You might click with certain patients you're not going to click with for a variety of reasons. They have more choices. Again, I mentioned the call coverage. It's also really cool. So I was doing DPC for a year and a half before I hired our first physician to work with me. And I didn't feel like I was missing something necessarily, but after having that doc come and work with me, I realized how much I missed that collegiality of having another physician with you, working next to you, bouncing patient questions off of them. Even after being in clinical practice for 12 plus years, the doc I was working with was very experienced, but I would ask him, I have this patient, what would you do? Just having that kind of dynamic. It's different when it's you and maybe the MA or the nurse. Strategically, and we'll talk a lot more about this, as a one doc practice or a micro practice, it's going to be a lot harder for you to go after businesses. Even if it's a 10-person business, a 100-person business, I think it's a lot more difficult. And then we'll get into, if you want to have more location. It's also, more appealing when you're trying to recruit doctors, right? So I would say the hardest hire is your first doctor hire because they're going to be looking at this and saying, are we going to get along with each other, personality-wise, financially? Are you going to be able to sustain this? Is this practice going to be around in 2 years, 3 years, 5 years? So this is myself and Dr. Adam Balin, who was the first doctor that I hired, and I'll talk more about him. So this question has come up a lot of how do you pay the doctor that you hire? My personal opinion about this is that you are investing into your practice. I didn't take a salary for the first 2 years. I moonlit for the first 6 months or so. I had a lot of money saved up, just burned through my savings, But the idea is that I'm investing into this thing because I think I value it, and I think down the line it's going to pay off in some way. So I'm paying doctors more than I'm paying myself in the beginning. So I did have a base salary that I paid doctors that I hired. But so what are the challenges of this? Finding the right doctor, how do you pay them? Again, I think it is very difficult. I've been on panels with Vance Lassie, and him and I have slightly different strategies about hiring docs. But some people say, I can't find a doctor. Well, if you aren't going to pay them at least a certain amount, you're not going to find a doctor. In our area of Madison, Wisconsin, a family medicine doc can make $250,000 to $300,000 in an employed position. They're paid well. They hate their job, but they're paid well. So if I'm coming to them and saying, I'm going to pay you $80,000, you're not going to find any doctors. So we pay a reasonable base salary. You're going to take on, more responsibility, maybe more financial responsibility. And then I'll talk more about these other things about what to outsource, taking on greater administrative roles. So the other type of DPC, I hate to call it DPC. Again, I get into trouble on social media and LinkedIn and stuff because I don't have a boss anymore, so I can call out whatever I want. I don't get in trouble. So the One Medicals of the world and the Everside Health used to be Paladina, the MDVIPs, these corporate DPCs that we are, in some ways we're competing against them and in other ways not. But they are typically employer-based. Usually large corporations are utilizing these. There are advantages and disadvantages. Some doctors in the room might have previously worked at some of these companies. I know in Wisconsin we have a number of DPC docs that started their own practices that were with Paladina Health, which is now Everside. But I just kind of like that second picture because it has the NASDAQ and all these people applauding. It's almost the antithesis of most of our DPC practices, which are not corporate. Then you have this kind of concierge medicine model, and a lot of times I think there is kind of a misuse of the term DPC when it's actually a concierge practice. My idea for DPC is that we are making our membership cost affordable to the average person, right? So if your monthly membership is $300 a month or $500 a month or $5,000 a year, I feel like the average person probably is not going to pay that. So we try to keep it affordable in the DPC model, but concierge would be maybe you're wanting to focus on a more higher end clientele. You have a smaller panel. You typically still charge insurance. And again, I feel like the expectations will be different if you're charging $70 a month versus $300 a month. So you might attract a certain type of patient. This is Madison, Wisconsin. If you've never been there, it's on an isthmus. It's really cool. So we have two large lakes on either side. The downtown sits right in the middle. And we are also hiring. Well, we're always hiring. So if anybody wants to move to Madison, Wisconsin, it does get cold in the winter a little bit. But so envision, kind of I think I always knew that my goal was to not be alone in a DPC practice. I wanted to hire more docs. I don't think I had a number in mind of what that would look like. But I think I also always knew that I wanted to have more than one clinic. But if you kind of think of those things ahead of time and kind of prepare yourself maybe financially, mentally of what that would look like. So this is another maybe opinion of mine that I feel like is not stressed enough. So when you are building a DPC practice, and if you are the only doc, if you're in a micro practice, for your practice to be successful, you are not only selling DPC, the model of DPC, you are selling yourself, right? Because you could go out to, whether it's an individual patient or a small business, and you could sell DPC and they could say, this sounds really good, but I'm not sure about this guy. I'm not really sure if I like that guy. So you have to be likable, you have to be able to sell this, and you're selling your specific practice, right? So again, if you're not somebody that likes to sell or likes to be in front of people, maybe that's something you outsource. Maybe you join a DPC practice where you have somebody else that's doing the selling part, but that is something you need to be comfortable with. And again, I think maybe this is not something that's talked about enough, but it should be, right? And you might not know whether you're comfortable with that or not. I have no prior business experience. So I had no experience going up in front of employers or individuals and kind of selling this. And you refine it through the years and you get better at it, but you have to be comfortable doing it. And if you recognize that that's not your strength, then you need to find someone where they're either going to help you do it, which again is somewhat of a challenge because usually you're the one that has the passion for it. So if you're the one doing the selling, that's going to be ideal. The other part about this is, I think one of the key parts I would say of that I want to convey is differentiating yourself from the system, right? So what are we offering? And this kind of goes back to your elevator pitch. And when the last panel, they talked about when someone calls and says, I have insurance, what is this, or do I need this? So what you are selling is access to care. You're selling a different level of care. You're not selling insurance. In Madison, Wisconsin, we have a heavily insured population. I think 95% of our residents have insurance. It's really crappy insurance, so we are selling a different level of care, something you can't buy through insurance. When I present to employers, I say, I don't care if you have the Cadillac insurance policy, you have a $0 deductible, zero copay plan. You can't buy this with insurance. So you're $70 a month. There is no Courts Dean plan that you can buy where you're going to have a doctor that's going to spend an hour with you. You're going to have a doctor that you can text after hours. That doesn't exist in the system right now. So you have to be able to sell that to people. And the differentiating yourself from the system part, again, going back to you'll hear a lot of different opinions about this, and especially, there is a school of thought within the DPC community, which I disagree with, that you design a practice for yourself, and you all can do that, but you decide, okay, I want to work Tuesday and Thursday, and I want to work from 8 to 12, and then I want to stop taking calls at 4, and that is totally your choice. You can do that, but you will not differentiate yourself from the system when you do that, right? Because you're selling access to something, right? So especially in front of businesses, because businesses will expect you to be available. You can't just not be available Monday, Wednesday, Friday. That's not to say that you personally have to be available. That kind of goes back to this idea of, do you build a practice where there is other doctors there that you can kind of have that coverage, which is kind of what I attempted to do. This concept of an ideal patient. So again, if your goal is to have a micro practice and have 200 patients, and you like taking care of mothers and babies, and that's your niche, and that's what you love to do, more power to you. That was not my goal. So my goal is every person that walks through the door, everybody needs a primary care doctor. That's not to say that I have not had patients through the years where I sit down with this person and we talk, and I'm just like, you know what? I don't think that this is a great fit. I usually make it it's me, it's not you kind of conversation. I don't think I'm going to be able to meet your expectations. I think you would find a doctor that's better able to meet these expectations. So it's not to say you have to take every patient that walks through your door, but I do think you should cast a wide net, right? If we are trying to grow a practice, cast a wide net. This is why we became family medicine doctors, right? We take care of babies, we take care of elderly, we do procedures, we do urgent care. If you pigeonhole yourself too much, that's going to really restrict your growth. Which brings me to, why do DPC practices fail? And I know this question has been brought up sometimes. I think an entire lecture should be probably done about it. But practices do fail. I think Josh Umbar has mentioned within the Atlas community, he sees 12 practices close a month or something. So while it's not something that's super common, it's something that's common enough to where we should evaluate why this is happening. You have to kind of ask yourself, do you want to run a business? Again, do you want to be responsible for all of these things? Are you going to outsource all of these things? Again, back to this concept of selling yourself. You are going to be the salesperson for your practice. I also would say that I hear people kind of set unreasonable goals for growth. I am a worst case scenario person, so I look at things and I think, what if this goes really bad? I'm growing at 5 patients a month kind of thing, and so I need to prepare myself. I sometimes hear people say things like, "Well, I'll be making an income after 6 months." Don't prepare for that. Prepare for a year, 2 years. If you have a spouse that is making a decent income and they can subsidize you until you're profitable, that's ideal. In my situation, I think I shared this at the summit talk I did. I basically went through a divorce during the start of my DPC, so I had no additional income. So, and also to say that you can do this by yourself. It's great to have a supportive spouse, but if you don't have a supportive spouse, you can still do this and be successful. So I would say set reasonable goals, worst case scenario kind of goals. I also think that you need to invest in marketing. I know a lot of people out there that will do, they'll say, I'm not spending any money on marketing because I don't have money. I'm not even paying myself. Again, we have sort of a unique market in Madison, Wisconsin, but I would say the first year in, I spent $40,000 on marketing. I wasn't paying myself anything. And now we spend probably $50,000 to $60,000 a year just on marketing. So I do a radio show, we do radio advertisements, we do bus advertisements. I'm trying to think of what else. But yeah, so that sort of thing. And that stuff is not cheap. But again, in some ways, I'm competing with the bigger systems, right? So people see my bus ad go by and they've never heard of DPC. They call the office. So again, I haven't quite figured out the numbers to see if it actually pays off. But so not investing enough in marketing, burnout. Again, burnout is true even through a DPC. Just because you're leaving the corporate, employed system doesn't mean you can't become burnt out. And that kind of brings me to that last point. And Dr. Adam Balin that I work with is a very smart doc that's been practicing for 30 plus years. And he always says, are you running away from something? Like, is this just, are you doing DPC because you're running away from the past, harm that you had through the corporate health system? Or do you actually want to do this? Do you want to start a practice and build a practice and put all the time and energy and money that it takes to do that? Because if it's just running away from something, DPC is not necessarily the best choice. I mean, you have to kind of just evaluate that for yourself. So again, I would say that be careful who you take advice from. Again, you will hear a lot of opinions just even in different DPC conferences, including this conference. You'll hear sometimes from DPC practices that are earlier on. Some of them are later on. Again, one DPC practice doesn't represent all, and again, what's worked for me doesn't necessarily mean it's going to work for everyone. But I will say that there are very different markets. There are very different, populations of people. So in Madison, Wisconsin, like I said, we are heavily insured. We are a university town. We have a lot of university employees, state employees. We're the capital. I know in places like Florida and Texas, you have a heavy uninsured population. But anyways, I'll give you my story of the broker. I think I've told this story a lot, but so the broker that met with me 2.5 years ago, so this goes back to the how do you get employer group. So I have a patient that owns a business with 50 employees. So she loves DPC. She goes to her broker and says, talk to Dr. Hemkes, and I want to offer this to our employees. And she has really good insurance for her employees. So the two brokers begrudgingly, come into the office. It was 2.5, 3 years ago, maybe. They're kind of like looking around skeptically, like examining all the rooms and trying to find things wrong. And so we sit down, and I give them my little elevator pitch, and one of the brokers sits there, and he's like, "Yeah, sounds great, but I'll tell you why it's not going to work." And I was like, "Well, yeah." No, he didn't say it that way. He said, "Yeah, I'm not thinking this is going to work." And I was like, "Well, could you tell me why?" And so he's like, "Well, we're in Madison, Wisconsin, and people are kind of stuck up here, and they all want to go to the University of Wisconsin for their medical care. And then why would somebody drive past a couple of UW clinics to come to your clinic when you only have one?" I think at that time we had 1 or 2 clinics. I can't remember. Why are they going to drive past these other clinics? The other reason he gave me was he said, these large companies, they don't really care how much they spend on health insurance because, they just pass that, that cost on to their customers. And I was like, okay. And then the last thing he said was, aren't you just taking like the low-hanging fruit? Like these sort of practices are just taking the low-hanging fruit away from the hospital, which was the funniest one because I don't think the hospital is going to go out of business anytime soon. So you'll get these naysayers that the way I view it is that they just don't get it, right? They don't fully understand direct primary care. But the ironic part is that 2.5 years later, the same broker brought me a business of 1,000 employees that we now take care of. So it's the same very skeptical broker. So they are coming around to this. The other one you'll get is, and I think this is more when you first start, but maybe, the cheerleaders of like, oh my gosh, I had a different broker when I very first started. I was at an expo. Expos don't work really. But so I had a booth at an expo, and this woman runs up to me. She's like, "Nicole Hemkes, I've been looking for you." I'm like, "Who are you?" And she's like, "I heard about you, and I heard about this direct primary care. I know all about it, and I'm going to start sending you employers." I'm like, "That's great. Yeah, please do that." And so in the next 2 to 3 years, I got 0 employers from her. So anyways, there'll be people that kind of, boost you up, which is okay. What I will say again is every DPC practice is different, but if your goal is to grow and have more than one doc and have more than one clinic potentially, look at ones that have been able to do that and maybe see if there's certain commonalities in those practices. So my theory is that for DPC to truly scale, again, it's fine to have micro practices and design your own kind of niche ideal patient practice, but I think for this movement to truly scale, we need some physician leaders that will have practices with multiple docs, regional, you don't have to take over the world. I have no goals to expand into other states and become a corporate healthcare system, but I would like to be able to have some clinics in our area of Madison, Wisconsin, and I think if we have more of that locally, this becomes much more appealing to employers. Once this becomes much more reachable to employers and we can compete with these corporate on-site clinics, then we truly break into this market more. You have to have some consistency of services again. You have to offer better access. So again, you are selling this, so I went in front of this corporate, again, and I have no practice administrator. I mean, it is just me. I do marketing, I do the payroll, I do HR. And so I go in front of this this corporation that we now take care of 1,000 employees, and I'm going up against, I had to do a request for proposal for them, and I'm going up against Everside Health and like a couple other on-site clinics like MDVIP, and so they're sending in their like COO and like 2 doctors, and it's just me up there. And part of what I was pitching to them is that we are local, so we're based in this community. Our doctors live here. We know this community. We know the other specialists, and you should also pitch that. If you're locally based, there's a lot to be said for that. We have to offer a higher quality of care, right? So most of our patients, in our case, have insurance. So again, we're differentiating ourselves from their insurance. We're offering better access, higher quality care, more time with the doctor, which is obviously gonna provide higher quality care. And again, there's a lot of talk about pricing, and people, I feel like on the social media sites, people will post and say like, should I increase my price by $10 a month? And of course, everyone says, do it. You do it. You value yourself. Do it. And it's like, I get it, but at the same time, you are creating a barrier to more patients joining your practice. It is going to be more appealing at $70 a month than $80. And believe me, there are people that will make decisions based on $10 a month. So what I would say is that, set your pricing to where you're not going to create barriers for people to join your practice. So just to be transparent, and you can look at all of our prices on the website, but we have not increased our prices since we opened in 2019, January of 2019. Oh, and that, these are pictures of some of our docs, and I'll show another slide about that. So our story, or my story, is that started planning for this in summer of 2018. I went to the DPC nuts and bolts in December of 2018, and then opened the practice in January 2019. I did about 6 months of planning. Opened it by myself. I took no loans. Had no outside business contributors, and then was by myself. Hired a medical assistant about a year in part-time, and then a doctor a year and a half in. So again, kind of touched on this already. When you're one doctor, you have low overhead. It's pretty simple. You have all the control. I personally didn't really like it. I mean, I like having all the control, but I don't like not having call coverage. And again, I just didn't think strategically it's a lot harder for me to sell this practice with one doc. You also limit your scope of services, right? So the doctor that I brought on, he's an old school family medicine doc, so he still does vasectomies, he still does tons of joint stuff, he does something called prolotherapy. So he offered things that I couldn't offer, which was, from a business perspective, is a good thing. So that also is something to consider. And that's another picture of Adam Balin. So again, going back to this idea of how do you fund this person? Are you willing to not take an income for a couple of years to be able to pay this person's salary? And the way I'm looking at it is for the first 1 to 2 years as they build their panel, I am, giving them my income, and then after they hit that, hopefully 1.5 to 2 years, they are profitable, and then I am taking part of, their membership. So the way our practice operates is they get a base salary, and then when they hit around 350 patients, then it's a per member per month. They basically get a large part of what the membership fee is. I would say that one of the most challenging parts of having multiple doctors and employees is the HR part, and that's something that I don't know how you prepare yourself for, and again, you could outsource that. But hiring and firing, finding the right people, it's very difficult. I talked about marketing. So you have to decide what you're gonna outsource. I mean, you could outsource literally everything. You could outsource your marketing, you could outsource your HR, you could hire companies that do all of this for you. It's all gonna come at a cost. You have to kind of figure out how much time you're spending doing these things and whether it makes sense to outsource this stuff. For me personally, plus I'm just kind of a control freak, I like to do it all. But I just now, as of January, I hired someone to I do my bookkeeping through QuickBooks, but that's the only kind of, other than I have an accountant and stuff like that, but everything else I pretty much do myself. I would recommend against taking on too much debt. Again, like if you're able to, have some money set aside and be able to finance this yourself and not have to take on debt. This is one of our buses. So we started the Middleton Clinic in the bottom right corner. Actually was a plastic surgery clinic before we leased it, so that worked out well. And then East Madison. So Madison is funny because it's on this isthmus. So you have East Siders and West Siders, and the East Siders don't want to drive to the west side of town, and vice versa. So that's why we put a West Clinic and East Clinic. We built out the clinic in East Madison about 1.5 to 2 years after the practice started. And then in March of last year, a year ago, we built the Janesville Clinic. We took an old floral shop and renovated it. And then we just purchased we purchased the building on the bottom left, and we'll be opening a 4th clinic in 2 months. So we have 4 locations. Again, strategically, that's really nice if you're going after employers, and you can say to them, if you can pitch the employer and say, hey, we have a clinic that's 5 minutes away from you, or we have a clinic that's, down the street from you. That is really gonna help. Convenience, accessibility, getting the buy-in of their employees because you have multiple sites. So these are our doctors. So the last 2 listed up here were new hires, and they're starting in the next 1 or 2 months. I always, when I'm pitching this to employers especially, I show a picture of our doctors. Again, I think there are some stereotypes that because something is less expensive, it is lower quality. That's also part of the discussion, is like there is no correlation in healthcare between quality and cost. Actually, there's an inverse correlation between those things. So a lot of times the things that cost more are actually lower quality. So I show this to them to say, look at our doctors. These are experienced, highly trained physicians. 2 of the docs up here were at one point the director of primary care for large corporate health systems where they had hundreds of doctors, underneath them. So I show this to say, these are doctors who got burnt out in the system and left the system. So just to sum it up, I think you need to have a vision of what your goal is. And if your goal is to stay a micro practice by yourself, that's totally fine. And then you're going to have kind of a different strategy if you want to hire more docs, if you want to have a second clinic. If you believe in yourself and what you're doing, and you truly believe that what you are offering is better than what the hospital offers, better than what the employed, family medicine doc can offer, then that will, transmit when you talk to people, and you'll be able to convey that to them. I think you should always prepare for challenges, as I mentioned, financial challenges, divorces, unforeseen things that can happen, setting reasonable expectations. And my plug is always to say, if you don't want to run a business and you don't want to take on all that financial and personal responsibility, it is not a failure to join a DPC practice. You're still going to be much, much happier than in the system. So that is all, and then I will pass it along, and I think we'll take questions at the end.